So it's a pleasure for me to be here and just talk after Denise. It's always a pleasure to hear her. And so for this tutorial, I was thinking on sharing with you guys mostly the strategies that we have been working to develop the protocols for the use of photodynamic therapy for antimicrobial response. But before starting my talk, I just want to, as other colleagues have already mentioned, we recently lost our great professor, Sergio Mascarenhas. And this is just to acknowledge for all his life, dedicate for science, for education, and especially for our community here at the São Carlos Institute of Physics. This is a huge loss. And I was just going to acknowledge this and thank him for all his productive life, dedicate for all of us that works here and works with physics mainly. But getting back to the talk, so one of the main motivations for this kind of application of PDT, this is one of these, and Lilia, the first tutorial has already mentioned the antimicrobial resistance. This was one of the reports provided by the United Nations in 2019, just before this COVID-19 pandemic. But in this case, they were already like placing this alarming data that we can reach around 10 million deaths annually by the year of 2015 if no effective measurements are taken to control the infections caused by resistant antimicrobial organisms. And of course, this is a huge loss, some lives, and it is also together with a huge also economical loss. So any country in the world will be affected. And that's why, I'm sorry, that's why we also working with photodynamic therapy, we are taking a look on these specific alarming reports. And as everybody is facing in the world from since last year, then came COVID-19. So as I'm gonna show you guys in the next few slides, PDT can also be a potential alternative in the case of these infections, disease that are caused by new pathogens, as in the case of SARS-CoV-2. And PDT, I guess also most of the audience has already known, but this is a kind of a treatment that in fact we use light to activate a molecule that is called a photosensitizer. And in this case, when it is activated, the main mechanism of action is relies on the production of the singlet oxygen, which is a highly reactive species and highly oxidative species. So in this case, where it is produced, this is gonna result in the damage of different biomolecules. And in this case, what we are looking for is the microorganism cell death. So for the ones that have never seen a photodynamic response, this is a confocal fluorescence microscopy. And what you are going to see here, those are amoeba. This is the natural outfluorescence of amoeba. And this is low fluorescent, except from some intracellular emission here. And in this case, we treat those amoeba with curcumin, which is one kind of photosensitizer that we can use for the antimicrobial PDT. And the curcumin has a highly fluorescent emission at the green spectrum. So this is a short video. You are going to see that the amoeba becomes highly green fluorescence. So they indicate that the curcumin is entering on those microorganisms. And then even the light of the microscope can excite the curcumin. And then you're going to see, like in this case here, the leakage of the intracellular material. What's in the case of the cell wall disruption and the release of this material. So we are going to see here, it's the cell, the death of those amoeba organisms. And in this case of the antimicrobial PDT, what is important to take into account that it's a large and different microorganism spectrum. So we have different types of organisms as bacteria, as fungus, as virus, and all these different organisms have different cell wall characteristics, and these will influence the type of and the interaction of the photosensitizer with these different biochemical and the structure cell wall. So this is important to take into account to choose the best photosensitizer that will interact more selective with your microorganism and not with the mammalian host cells. So the first type of experiments that we perform when we are dealing to develop a PDT protocol is to check the photosensitizer interaction with these microorganisms. So we can run like those experiments in planktonic cells. And here are just one example of using two types of chlorine. There's just a difference between one of the lateral components. But what I want to show you guys here is that with different types of bacteria, this one is gram-negative, Staphylococcus aureus is a gram-positive, and this is Candida albicans, which is a fungus organism, that we can look at these different photosensitized concentrations. In this case, we just set the same parameters of incubation time and also the fluence or the energy dose that we deliver for this microorganism culture. And then we can check the survival fraction, for example, in the colony, the unit forming colony per males. And then as you can see here in planktonic cells is quite a very nice inactivation response that we can achieve with PDT. For instance, from those up here, from bacteria, we are coming from the 10 to the 9 log units up to a complete inactivation of those organisms. Usually the fungus are more resistant or are in fact less sensitive for the PDT. So then we have to use usually more concentration or more light dose, but again, we can really have very nice inactivation, in this case from 10 to the 6 log units. But mostly of our infectious disease, the microorganisms are not going to be in the planktonic form, which is the isolated for individual forms of the cells, but they are going to be in biofilm structure, where we do have already like a well-developed extracellular matrix, mostly from sugar molecules, that provides to the microorganism cells a kind of a protection for any kind of treatment, including PDT. And in this schematic draw, what we can see that even to have the right and the homogeneous diffusion of the photosensitizer, it's going to be limited when the microorganism is in this kind of structure. And even if we can go to some of, especially from the fungal infections disease, the microorganism can be even like in the middle of the mammalian tissue. And then this is becoming even harder to treat those kind of infections. So one way that we can overcome this kind of limitation and the less response for those that work with biofilms, it's really hard even to get inactivation from like 10 to the 3 or 4 log units. And so one of the ways that we can do that is to, in fact, combine the aPDT with other techniques. One of the things that we have been looking at is to combine using ultrasound methodology. And in this case, we are comparing in the S. aureus biofilm, the inactivated that we can get individually from the photodynamic therapy, or the sonodynamic therapy, or in the combination of both therapy, just delivering the ultrasound together with, in this case, was with curcumin, activate with the blue light. And I'm just going to show the final results here. And the combined treatment is those bars in this orange color here. So we always get with the different protocols that use the highest amount of inactivation of the bacteria here, which this kind of inactivation that we, especially with this group here, in combination also that we use in this case a surfactant, we can achieve several logs here up to like almost like 8 log units of inactivation. In this case here, we also add some salt. Dr. Hambling has reported an improvement of just adding salt, which is a very nice and simple way to improve the PDT response. Always when we combine again the ultrasound with PDT, we get the highest level of inactivation. So those are very nice results that we can achieve in biofilm. And I'm not going to show here, but also we have been looking, and people around the world also have been reporting the combination of aPDT with antibiotic therapy, that even for resistant microorganisms, that they are achieving very nice response as well. So there are some cases that antimicrobial PDT is not going to be a single treatment choice, but probably we are going to use those combination forms and then really getting a more effective results on these well-organized microorganism structures. And I'm going to move with this case that we perform all the validation of the aPDT response on the in vitro inactivation experiments up to the clinical application in naturally infected animals. So I like a lot this case, because then I can show you guys how we plan to do this kind of development of the aPDT protocol. So this organism, in fact, is classified as an omicet, but the structure in even this life cycle is very similar to a fungus. Here you can see an optical microscopy, this HIFA grow characteristics of the fungus. This is the microscopy view of these P2 insidioso grown in culture. And this is a fluorescence microscopy that we are targeting the cellulose. So this is a health problem, the infection caused by this organism, because one of the main target in the cell wall by the antifungal treatments that we have available is ergosterol. And in fact, these organisms here, doesn't present ergosterol in this cell wall. So that's why it doesn't have any kind of response to those antifungal treatment options that we have available. And additionally, they have these cellulose, which provides a very resistant cell wall structure. So we just want to try to check if PDT could work, because in fact, this kind of infection do not present a conventional treatment available, except from the surgical resection. So P2 insidioso, in fact, habitating these aquatic plants. And here you can see in the microscopy, they start to produce some spores that at the end, those spores are released in the water. And if there is an animal in this infected or contaminated water and can have any kind of a disruption of the epidermis, those spores can enter in the skin of the animal and then start to produce the clinical infection, which start with the skin lesion. Just to note, I'm going to show some not very nice pictures, but this is the kind of the lesion that we can have. This organism has a very fast growing rate. In the case of the horse, which is the main animal that is infected by pityiosis, it can even grow and affect the bone. But we have also different, as you can see here, different animals are infected, and the humans are in fact mostly in Thailand in the rice plantation workers. And also there are some difference between the animals' evolution of this lesion. This case in the dog is not as invasive as in horse, but has this, again, fast growing. And as I mentioned before, the therapeutic options, the first option is surgery. There are a few immunotherapy. People try to produce a vaccine for the P2, but in fact, it's very controversial, the results that they achieve. And mostly they try different treatment combination, but at the end, in the case of humans, usually it is tried several surgical resection. If it is not get rid of the lesion, then you have to amputate the member. And in the case of those animals here, at the end, they have to be sacrificed. So we first try to check the best photosensitizer for the inactivation in vitro. So we try a methylene blue, we try a porphyrin derivative, and also a chloride. And in fact, those are the inhibition rate. So the best results here is the one that we control the growth of this P2 in vitro. It's just for you to have an idea. The top image here is from the beginning of the experiment. And this is day 0. And then this is 24 hours after, in this case, no treatment at all. And this is 72 hours of growth. So this is what I'm saying to you, that's a fast growing. And this is an example, I'm sorry, an example of those effective response that we can control the growing rate of the P2 insidioso. Then we checked also with those 3 different photosensitizers. We checked different levels of concentrations and 3 different energy levels, trying to get the best response. Those first columns here are the treatment using the amphotericin B, but as I mentioned to you, there is no very nice response, but this is one of the treatment available, I mean, presented as an option to treat the pityiosis. And as you can see here, the best photosensitizer that we got the results in vitro, the chlorine. This is the name of the compound. And methylene blue was the worst photosensitizer with this comparison. When we check the confocal fluorescence microscopy, we know the reasons here because those photosensitizers are highly fluorescent, so we can track and monitor the photosensitized distribution. And as you can see here, the methylene blue has some interaction, but it results in a very heterogeneous distribution of these methylene blue. Porphyrin got a higher distribution and a more homogeneous, but at the end, the chlorine, as saw again here, it was the best photosensitizer when we consider the distribution of the photosensitizer in this kind of biofilm growth of the P2 insidioles. And those are the images taken after the PDT radiation that we can see for both methylene blue and chlorine. We had almost the complete photo bleaching or consumption of the photosensitizer. And in the case of the porphyrin, we had still some porphyrin left. So probably here we could even use a higher energy dose to have a more PDT response. Here I'm going to show you the electron microscopy, scanning electron microscopy images that again we could check the same kind of response. With the porphyrin, we have a more like a partial damage provided to those hypha growth here. And this is why probably we didn't achieve the highest level of inactivation, because some of those hypha may have this damage here, but could be recovered after the PDT session. And one of the images here that we also show the partial response, that we can have a very nice response on the surface of those, the biofilm. But as you can see here in the bottom, we have the hypha with the cylindrical form and without damage. So that's why we can even have the growing rate. In this case of the PDT has not a complete response. So the best results were with this chlorine compound using 0.7 milligrams per mil, and at a high energy dose, 70 joules per centimeter square. But we can see here in the microscope image that we have a complete destruction of this biofilm, and that's why we don't have the growth anymore. After the results in the in vitro, we moved to the animal model. So the animal model that is available for PTOs that is reported is in rabbit. This, as you're gonna see in the next slide, at the end it was not proven to be a very nice model for us because it's a different kind of lesion that is induced. But anyway, in this case, we use, so infected and produce a lesion on the paw of the rabbit. In this case, we use intravenous injection, so a systemic injection. And then we didn't try with methylene blue, but we tried with porphyrin and the chlorine compounds. We checked the photosensitizer distribution, the lesion, using fluorescence spectroscopy, and we set as a better drug light interval of 4 hours. And then we deliver 200 joules per centimeter squared. It's a very high energy dose for infection disease. It's the same level that we use for tumor treatment. But the reason is here that we can see, as I mentioned, at the rabbit model, we don't have that ulcerated lesion. We had a more like a tumoral-like lesion that we have this an increase in the volume. We could see inflammatory condition. This is the image taken just after the irradiation of PDT. that we can see already an edema and more inflammatory condition. This is 2 days of treatment that we had even like still left some necrotic tissues that we had after the treatment. And this is the image after 10 days of treatment. So at the end, we remove this tissue, and those are the immunohistochemistry marked specifically for these microorganisms. As you can see here in this top image, those dark green filamentous structures here is the PTOs marked positive. So this is from a partial response lesion. And this is the one that we achieved. Again, here we got the better results with the chloride. And this is one of the slides that we had a complete inactivation. So this is the negative for the P2 insidioso, in this case with this kind of response here. And at the end, this project, we finalized treating some horses that were naturally infected by the P2 insidioso. So this is kind of the lesion that we are facing on this kind of animal. So these horse had already had 2 surgical procedures, and this is 24 hours after this second surgery. In this case, for sure, we are not going to be possible to use the systemic injection. So we just performed the intralesional injection of the chlorine, the best photosensitizer that we had. In this case, we didn't check, we didn't have the fluorescence system to look at the distribution of the photosensitizer. So at the end, and again, since it was intralesional, we just performed the irradiation just after a few minutes of the injection. And here we couldn't have a higher radiance. This is a very large lesion here that at the end took us a total of 6 hours of irradiation. But we performed the same amount of energy level in this treatment here. So this is the images taken 5 days after this first PDT session. This is already like for clinical aspects, a very nice response compared to the former one. This bleeding that you see here is just because the animal had to use a occlusive curative, and when we remove due to this kind of a granulation tissue that we have here, we have a high vascularization, those bleeding spots. But for here, we didn't have any kind of a clinical aspect of the infections, but unfortunately, 15 days after this first PDT session, we had this recurrence of the lesion here. In fact, that is non-treated part of the lesion. Those are the canker aspects that we have these P2 insidioso in horses. So in that time, we just perform a second PDT session on those parts that we could see this clinical infected lesions, again using the intralesional application of the chloride. And this was the aspect 15 days after the second PDT session. Again, we didn't have any kind of clinical aspect of infection in the lesion. The motor functionality of the paw of the horse was recovered. The animal was already having a nice motor function. This is the first clinical aspect, and this is after the second PDT session. And we could even look at some parts of reepithelialization area, which again, this is only possible when we have control of the infectious disease. So unfortunately, this animal had to be sacrificed because it was detected a distant lesion in the mammary glands. So P2 insidioso can go through a lymphatic vasculatory system and go get distant infection and systemic infection in this case, so this animal had to be sacrificed. And as everybody knows, PDT has a only local response, so we could not have done anything for a distant infection. This is the second case. In this case was a pregnant horse. And the idea here was to really control the infection so the animal could have the delivery of the small horse. This is in the belly. Again, we had the intralesional application of the photosensitizer. In this case, we even use a fiber inside the lesion. This is just a cylindrical tube, a glass cylindrical tube. Here's the kind of exudation that we have with the just after the response. This was a single session. The PDT was in Pará, in the north part of Brazil, and I don't have any kind of other clinical pictures from this animal. But at the end, what we could have that 4 weeks after the PDT, there was the delivery, and the horse was born completely normal and no infections of the baby. As I mentioned, we took several hours, especially for the paw cause, that lesion on the paw of the horse. And then we're coming back to the lab. We just designed this kind of LED system that we have a very broad area that we can use illumination at once. And this is called our PTOSIS equipment that we can then have a very nice irradiation to try to reduce the irradiation time for the procedure. And I just want to, Sebastian, can you just give me how much time do I still have?
1 or 2 minutes.
Okay, so I don't think I'm gonna be able to report this one here. I just wanted to mention that we are together with the University of Health Network in Toronto.
Sorry, Cristina, I misunderstood. We have 10 minutes because
okay.
Okay.
Okay, so just moving back a little bit. So the second example of developed protocol that we have for aPDT is for using together with a procedure that is called ex vivo lung perfusion. This is a machine that they connect the lung from after it is removed from the donor. And they maintain the lung here, connect with the perfusion liquid, which is the preservation fluid, and also connect with this gas machine that's going to keep the lung in function for the respiratory function. And one of the reasons here that we want to develop is some antimicrobial technique is because some lungs can be from donors that are infected, in this case with hepatitis C virus. And this is one of the reasons that may reduce the number of available organs for transplantation when the donor has any kind of infectious disease that if it is transplanted the organ for a recipient for another patient, these new patients, you get this infectious disease. And as everybody know, any kind of a transplantation patient is already the clinical status of these patients is already a huge concern. So for sure, we don't want any other problems relating with infection. And in this case, as we have here the organ outside of the patient and outside of the donor, but it is connected to this kind of machine, we just performed the development of the treatment here in the liquid perfusion solution that is outside of the lung. So the idea here is this is conventional ex vivo lung perfusion. So this is the perfusion liquid. As soon as it starts to flow inside the lung, after a few minutes, you have already like contaminated this solution with the hepatitis virus C that is from this donor lung. And the idea is to perform here. In fact, we use aPDT, but also just UVC, because we are not irradiate the organ, we are irradiated the infected solution. But the idea is after running this kind of treatment here, depend on, as a function of time here, we are going to be reducing the viral load of this infected solution. And as this is going in a loop here inside the lung, of course, if it is infected, it's going to go back here to the lung. But if we are inactivate the virus here, we are going to decrease the total amount of the viral load here in the preservation liquid, but also in the lung. So for those that want more detailed information, it's reported here in this paper. And for both of the photonic techniques that we developed, we had, as you can see here, both in the tissue, but mostly in the perfusate, we had the decrease in the viral load here. This is the UVC response, and this is the PDT response that was checked using RT-PCR. So we do have a very nice control, especially as I told you in the perfusate of using PDT, but also UVC. And in fact here, as we are not treating the tissue, for sure we are going to have a viral load still in this lung. One thing that was also tested in the case both UVC and PDT is if this kind of some still detected viral load by PCR for really infective particles for cells. So after this, using either UVC or aPDT, we get this perfusion liquid, and we culture hepatocytes that can be infected by the hepatitis C virus, I'm sorry. And as you can see here in the cell culture, even though the PCR detected some RNA of these virus, we could see that the resulted particle there is not infecting any kind of the cells. So even though we do have some viral load here, they could not infect the hepatocyte cells. Again, with the PDT, we have the same results. Here's just the plots that we have for different types of concentrations of the methylene blue, and different times also the irradiation. And also we compare just with the room light, so no PDT illumination specifically with 606 nanometers, just the room light of the surgical room. And this is with our device connect with the EVLP system using for PDT. But again, we do have a zero infection of the cells when we perform this kind of procedure. After that, people there in Toronto performed the procedure using the pig model, which is the preclinical experiment before going to humans, and just checking especially the performance of the transplanted lung after our UVC and PDT procedures, if the lungs were anyhow affected by those techniques. And though they compare different kind of functions of the lungs, as you can see here on those images here in the graphs, they didn't have any kind of difference compared with a control lung that was just performed the EVLP procedure. So for both photonic techniques, UVC and aPDT, so with this kind of response, we have that the lung organ that has been used, the PDT or the UVC procedure to inactivate the hepatitis virus C, didn't have any change after the transplantation in their performance, considering the functions of the lung. Even the histopathology, when we check there, the histology is light. There is no difference comparing the lungs, and even marked with some inflammatory cell biomolecules, trying to check the cytokines if there was any kind of difference. So now here also in Brazil, we have been using this same kind of protocols, but moving to kidneys and liver, looking for more these organs that in Brazil we have a higher number of transplantations. This is just the picture. This is from the LED device for the, for the LED device for PDT. And this is kind of just the device that we place together. This is the perfusion, ex vivo perfusion for kidney, that we just adapt our irradiation system to get this kind of performance or this kind of procedure in these applications. So just a few items here as a take-home message for this tutorial. I hope that I could convince you that aPDT is an effective and safe local treatment of infectious disease. Has a broad spectrum of target pathogens because due to the mechanism of action, mostly based on the production of oxygen reactive species, this is a non-specific biological target. And this means that we can have a customized protocol that has response on bacteria, on fungus, on virus, on different types of pathogen, and this comes a very nice advantage comparing to the antimicrobial therapy using antibiotics, because then if you have to design a new molecule for any kind of new pathogen that appears, it takes several years of development of this kind of treatment. In this case, PDT can be used with the same class of photosensitizers that are already available, but take into account that we have to look for the best one, looking at the pathogen and photosensitizer interaction. And then we customize the application depending on the radiation planning, dosimetry, the optical geometry that we have to use, depending on the target infected tissue, or as in case of, I show you guys for transplantation, we are just going to do the proceeding in a circulating fluid. And then also the possibility to have the different combinations of aPDT with other treatment options that may really produce a more effective treatment response. And for the results that I showed, the experiment and the studies that we have been producing, those protocols, those are the main people working. So this is a collaboration together with Professors Wanderlei Banhat, Sebastião Prata Vieira. We have those researchers working together with us, with the students, with all the projects, Doctors Natalia Inada and Lilian Muriyama. Those are postdoctoral fellows that working with those specific projects that I show you guys, and the graduate and undergraduate students. And mostly with the transplantation procedures, we have a collaboration, as I mentioned, with Professor Marcelo Cipel and Brian Wills from University Health Network in Toronto, Canada. Laila Pires, which was the student that performed all the experiments in PTOs. And again, right now she's working together with Brian Wilson in Toronto. And those are the people working together from the medical school, University of São Paulo, for the kidney and the liver experiments. So thank you very much. I hope I didn't advance too much in time, and I'll be glad to take any questions.